webinar. Today's talk is on early neuro-rehabilitation in ICU. There are a lot of challenges a physiatrist can face during rehabilitation of acute neurological conditions such as traumatic brain injury, stroke, etc. How to overcome these challenges and successfully manage the condition on physiatrist point of view, that will be discussed by Dr. Suparna Gangopadhyay. He is the Director, Department of Neuro-Rehabilitation, Institute of Neurosciences, Kolkata. He has vast experience in neurorehabilitation, well evidenced by his Department of Neurorehabilitation. Without wasting time, let us invite today's speaker, Dr. Suparna Gangopadhyay, for his talk. Over to Dr. Suparna. Thank you.
Thank you, Dr. Sahoo, and my apologies to all the viewers because there was some hitch up with the computer. So without wasting any time, I'll just move on to my presentation. So today's presentation will be on early neuro-ICU rehabilitation, successes and challenges. So just before I move into the real topic, just a bit of introduction about who I am, because I am sure most of you might not know me. So I completed my postgraduate in PMNR from IAPMR, Kolkata. Then I moved to St. John's, Bangalore, where I spent a short stint. Then I went to CMC Vellore, worked as an assistant professor at the Department of PMR. From there, been to Australia, worked in a spinal cord injury, traumatic brain injury, and amputee, because those were my real areas of interest. And then, without wasting time, after spending 7 years in Australia, I came back to my own hometown, Kolkata, where I joined Institute of Neurosciences, Kolkata, in March 2015. So since then, I have been working at this institute in the Department of Neurorehabilitation, and it has been a story which I really would like to share with you. Don't have much time, but I would try to have as much as inputs as possible, and I would definitely invite questions from you as well. So this is our boss, Professor R.P. Sengupta. He's OBE, and he is the CMD of our institute. Now, when we started this department, this is where we started our services, and this was a very small setup where actually we couldn't really cater to our patients in a small area. We had to gather almost 170 to 180 patients every day. So we had no other choice but to move to an extended service area. And this is our annex building where we have our outpatient department. So this was our initial neuro-rehabilitation ward. We have a dedicated ward to ourselves, because I am a firm believer of inpatient rehabilitation, because unless and until you have an rehab setup of your own, it is very difficult to put a footprint. And the more you have these sort of facilities, you will be actually looked up to. Then we had a small stint at a different rehabilitation center, separate than INK, that was in a different area. But due to some technical problems, we had to stop that. So ultimately, our dream is to set up an INK Neuro Rehabilitation Institute. But as of now, we have moved from a team strength of 70 from 6, because when I initially joined, we were only 6 of us. Now, currently, our team strength is 70, which includes all the nursing staffs from the neuro rehab ward as well. So, as you can see, this team this list has everything. When you look up the books of physiatry, this is basically the holistic team. So unless and until you have a holistic team, probably we are not doing the proper justice to our patients. This is our healing team. Now we'll just move through neuro rehab at a glimpse. What is the general awareness about rehabilitation? Massage, physiotherapy, de-addiction center, but I guess rehabilitation is much more than that. For all the postgraduate trainees, we need to understand that rehabilitation is basically a patient-centered approach. So we might have set up our own goals, but unless and until that suits the functionality of that patient, that rehab goal is probably not going to succeed, because we need to understand what the patient wants, or what the relatives want. What is the socioeconomic scenario at home? So unless and until we are aware of what we are dealing with and whom we are dealing with, it is of no use setting a plan. So it is basically a patient-centered approach with the whole team working towards improving the functionality of that patient and getting him back to his near normal uh, life, and trying to integrate him to his community or society. Now, rehab services need to be a 24 into 7 hours, because we have to have our share of services in the ITU, HDU, and the tracheostomy ward. Because unless and until we provide that services to our institute, it is very difficult for the surgeons to have the proper outcome of these patients, because most of the acute setup patients or the neuro patients as we deal with will be in the ITU for a certain period of time. While they're in the ITU, they will definitely have issues with chest. So our cardiopulmonary rehab physiotherapists, they take care of this whole gamut of patients whom actually they try to help with their weaning of the ventilation, decannulation, as well as improving the chest, reducing the chest complications. So we have tried our best to have a 24 into 7 rehab services, and we have been actually doing this for the last 6 to 7 years. So now we need to understand what the rehabilitation settings are. I'll just try to make you understand through these next few slides as to why these are so important. So the first important setup is an acute neuro rehab setup. Why is it important? Because here we can actually mobilize the patients early, and planning for their discharge can also be done. If you look up the reading there, it says early mobilization beginning the first day of intensive setup, while the patient is still on a ventilator, actually shortens the length of stay and improves functional outcomes. So I always believe starting rehab from the very first day is going to help the patient recover earlier and get back to his functional outcome better than the patient who has their share of acute rehabilitation. So this is how it is done from the ITU setup. Now, once the patient is medically stable, Then there is this step down or the post-acute setup. Now, again, there is good evidence showing benefit from early intensive physio as well as occupational therapy in the hospital for acquired brain injury patients and also with patients with having orthopedic complication. So the basic principle is getting rehab services as early as possible into any sort of be it neurological, be it musculoskeletal, be it orthopedic, any sort of uh, uh, problems that the patients have need to start off with acute rehabilitation as early as possible. So again, you can see the difference. There's one acute, then comes the subacute phase or the step down phase. That means the ward. Once these two things are taken care of properly, the discharge planning and the discharge of the patients becomes much more easier for the primary consultants as well as when the patient is transferred to under the neuro rehab department as well. So outpatient, now what happens once you start off from the acute phase, that patient psychologically becomes the part of your own institute, the part of your department. And once that happens, it serves two purposes. One is definitely we will be looking into the patient outcome. One is if you are in an institute, that also helps in a business model because these patients gather trust on the consultants, on the team, and they actually want to continue in your own department if you have a good outpatient department as well. We are lucky that we have a hospital to home services where we reach out to the patients after discharge. There are patients who might not be physically or psychologically motivated to come back to your outpatients, but these patients actually want services at home. So you need to have that outreach services provided through your own team members as well. So again, what I'm trying to reiterate is it is basically an hospital to home rehab services, hospital acute setup to an absolutely cold setup at home. Now, there are some controversies about it regarding using telehealth technologies, but I think COVID has COVID has helped us in starting with this. And again, this is also one sort of rehabilitation setup because there are some patients who are unable to come down, who just want a few services through the uh, telehealth provision, and actually we try to help them out through the medical consultation as well as the rehab therapist consultation as well. But having said that, unless I always believe in having the patient over in your outdoor physically rather than getting into these uh, telemedicine technologies. Now, what is early rehabilitation? Like if you look at the definition of these, it is less than 48 to 72 hours post-patient admission in the emergency or as soon as the patient is hemodynamically stable. So, as a rehab physician, we need to understand the definition of early rehabilitation. Ask, sir, what do you mean by early rehab? So, as I always say, we need to prove ourselves that we are in a situation to provide the acute care physicians help rehabilitation as early as possible, which could be a PEG tube, which could be a NG tube, positioning, chest physiotherapy, mobilization, early orthosis to maintain muscle length, early detection of neglect and apraxia. I will come to these in the next few slides. Speech and swallowing pathologist evaluation, assessment and cognitive rehabilitation by a psychologist. So these are the components of early rehab. And we as a rehab physician need to understand that unless and until these are incorporated in our goal setting, we are actually not providing the adequate services for an early rehab setup. Now, what are the advantages? Very important is the decreased mechanical ventilation and ITU stay, which reduces the hospital length of stay and increased turnover. The management will be very happy with you. But more than that, in terms of patients, it is decreased complications like your hospital acquired infections. Moreover, there is an increased functional independence at discharge. If you remember from the previous slides where I mentioned about the setups, acute and step down units, it always, there is an evidence to say, early the rehab starts, the better is the functional independence at discharge. And definitely there is reduced cost to the patient. So overall, you are actually helping the patients in terms of their reducing complications and improving functional outcome. At the same time, you are actually supporting your hospital or your hospital management with increased turnover. Now, if you look at this slide very carefully, this slide is actually from 1988, where Davidoff found that 40% of patients referred for physiotherapy alone actually needed physiatric consultation. So this is definitely something which actually boosts us that most of the centers, most of the referrals, most of the hospitals, what do? Refer to physiotherapy. Hardly they, unless and until you prove them that a physiatric involvement is needed, they won't refer that patient to you. Now, I still remember, I just wanted to share something with you. When I joined this institute 8.5 years back, when I used to, that time I used to be alone with six other staff members. There were all these referrals. And I went to see a referral initially. I wrote my goals and my planning. And there I mentioned OT, patient, and I mentioned everything as well in terms of the occupational therapy part. But interestingly, next morning, the patient was actually kept NPO because people didn't understand what the meaning of OT was. So this is the scenario which was there 8.5 years back in my own institute. And now we are happy to say that we have 5 masters in occupational therapy as a primary service provider as well. And that starts from the acute setup. And that gives rise to acute rehabilitation. So this is the role of a physiatrist. Now, most of you all might be reading books, preparing for your exams, but do you really understand what the role of a physiatrist is? Let me just explain to you. If you look at the sub slides, first of all is we deal with neuropharmacological management. That means pharmacological management is done by us. What we do, we liaise with our acute care colleagues. We plan a proper rehab program. We execute our ideas through the team. Very important part, timely discharge and follow up. More than that, I think this one sub slide which I've mentioned here is rehab is the portal of exit. It actually is. I'm not going to explain what the uh, how I have learned this, but in my experience, I have in a number of occasions seen that patients referred to us, the primary consultants might have missed out on something which actually we have picked up. And when we take that into account, the rehab outcome becomes much easier. Now, I always have this slide in my presentation because there are lots of myths and facts. There are myths like early rehab is too early. There is no life after stroke or brain injury or spinal cord injury. Spinal cord injury means that you will never be able to move and work again. But through the next few slides, I just want to explain to you that these are all myths. What are the facts? A few patients, like for example, SM, 18-year-old male diagnosed with GBS, progressive quadriplegia, dyspnea, dysarthria, dysphagia, and in extreme pain while he was admitted under a neurologist. Now, as a physiatrist, what were our challenges? The most important and the vital challenge is the challenge of prolonged ventilation. A GBS patient has been on ventilation for a long time. Through the services of our cardiopulmonary team in the ITU HDU, the intensivists were able to take him off the ventilator, but tracheostomy still remained. So a well-coordinated physiatrist supervised ITU rehab program is very important, which includes a good nursing care to prevent pressure injury, chest physio round the clock. For that reason, we need a 24/7 hours service. Early mobilization, including trunk facilitation, orthosis, as I mentioned before, and care of tubes. Why this is important? Because we need to decannulate. We need to get the tracheostomy out. The more the tracheostomy duration is prolonged, the risk of infection increases multifold. The risk of infection increases multifold. Whatever improvement the patient is having through pharmacological as well as rehab setup, again the patient goes back to his to zero outcome. So we really need to focus on getting the tracheostomy out as early as possible. Next comes the role of speech, language, and swallowing pathologists. Challenges: if you have a nasogastric tube, which almost all the patients in Neuro-ITU setup have. So we have to focus on NGT removal. As a rule of thumb, I still believe in 3 to 4 weeks of NG tube. We need to, if the patient needs prolonged enteral feeding, we need to remove the NG tube and go for a PEC tube. But before that, we need to do a FEES, a functional an endoscopic evaluation to see how the swallowing mechanism is. Along with that, we need to provide adequate nutrition. So all these factors are important because if the patient gets malnourished, the when the time comes for his actual departmental rehabilitation, the patient is weak. He won't be able to really engage himself in that intensive rehabilitation phase. So get the tracheostomy out as early as possible. Try to remove the NG tube as early as you can. Maintain adequate nutrition. So an exceptionally important part in neuro rehab ITU, which we are fortunate to have the services of our speech swallowing team. Swallowing should be screened at least within 24 hours of admission. Dysphagia, there is a dysphagia screening protocol. I won't get into the intricacies of that because those that will take a lot of time. Just look at the last line. Patients failing the bedside screening test should be referred for a FEES, which examines your swallowing mechanism. So now this patient was on ventilation, off ventilator, tracheostomy out, nasogastric tube out. Nutrition is very well maintained. No pressure injuries. I can vouch Institute of Neurosciences, Kolkata's nursing staff, a big salute to them because I have hardly come across any pressure injuries. Even with patients being in our hospital bed for months together. Now, look at this guy. So we have been following him up from the acute phase, and now he's in the department, having the physiotherapy and the intensive and the proper physiotherapy and the occupational therapy services. Now look, this guy was with us for almost 9 months. We have to provide him with some sort of leisure activities, spirituality, and he was a spiritual guy. So it was very easy for him to get into that mode. So now somehow these things help because the patient being in a hospital setup away from their own setup needs some sort of entertainment. Well, you cannot provide all entertainments in the hospital, but these things definitely give them that extra boost and that extra motivation to participate in the rehab setup. Now, this is our guy. I have his only dream was to get discharged from the hospital, go back to his hometown and play or beat the drums during Durga Puja. That is on the day of Nobumi when he sent me this picture. I haven't shared the recent pictures with him. He cycles for almost 60 to 70 kilometers every day. So this is the beauty. This is the miracle of starting early rehabilitation. Next, again, another patient, PK, 24-year-old male, polytrauma, head injury, subdural hemorrhage with incomplete spinal cord injury. When he was transferred under us, he had a GCS of E1 VTM3, multiple skin abrasions. He had an exposed tendon of left foot, which was somehow missed out. That is why I mentioned rehab is the portal of exit. And now look at that guy. So what were the highlights of his successful rehab? The crux is to take a risk in spite of negative prognostic factors. It happens. If you see a patient in the ITU for the first time, an injury, this, that, everything on ventilator, you just get perplexed that why? This is the job of an intensivist. This is not my job. But that is the beauty. The earlier you start, the earlier you take that risk and earlier, because look, you need to understand that you have a team with you and that team is your creation and you know how to handle the ventilators as well, even though the intensivists are there. But you need to take that risk. You need to prioritize the line of action in a polytrauma patient. Pain management, here we actually involved the plastic surgery, which was somehow missed out by the primary team, and liaison with other colleagues as and when needed. A very important thing. We always need to remember one thing. Rehab is 50% feeder dependent department. So we need to get all our colleagues on board. Need even if we know that we are the experts in rehabilitation, we are experts in a particular field, still it is always better to have a good team setup and a good liaison with the primary consultants, because they will help you with your future patient turnover and patient referrals. This is a very interesting patient. 52-year-old male, had a right frontotemporal, subdural, subarachnoid, polytrauma, assault. Now, what were his highlights of early rehabilitation? When this guy was transferred from Durgapur Mission Hospital, he had a E2VT M2. Now, what were his highlights of early rehab? Number one, again, which I mentioned before, early nutritional management with PEG tube insertion. The first thing which we did, we inserted a PEG tube. Here comes coma stimulation program, because this guy was in coma for 6 months. He was in another setup for almost a month post surgery. Then he came to us in a comatose state and management of neglect, part of the visuospatial perception deficit. So if you look at this, PEG tube insertion, as I mentioned earlier, has to be done as early as possible when you feel that the NG tube might not give you the best results, as the patient might need to be on that NG tube for a prolonged period of time. Now, I won't go into the details of what coma arousal is, just a few things which I would try to mention, which we usually use, and these are all evidence-based things. I haven't been a great user of hyperbaric oxygen, but we definitely rely on the other accessories of coma arousal, like pharmacological. There are a few medicines. I'm not going to the details of that. Sensory stimulation, very important part of acute rehabilitation. We need to involve the occupational therapy team as early as possible, so that they start off with their sensory stimulation program. Music therapy and median nerve stimulation, which we all do in our hospital. Dorsal cord stimulation, I don't have a hands-on experience on that, so I won't be able to really talk much on that. And transcranial magnetic stimulation, I'll just, in the next few slides, I'll just run quickly through all these sub-slides. So, coma stimulation, mainly to promote arousal and appropriate patterns of movement with interaction with the environment. Very important contraindication is elevated ICP or a patient throwing a seizure, or relative contraindication, a patient having a tracheostomy. Patient reaction must be very closely monitored. So these are the stimuli which we all know, but there are processes to actually do these procedures, and the occupational therapists are an expert in that. Very important part, each patient has to be each therapy program has to be individualized. Frequency 2 to 3 times a day. Visuospatial dysfunction. One important note on this, it usually resolves over time, but initially it might interfere with the rehab program, because the patient is not able to recognize his environment. One important thing, if no recovery even after 6 months, that is basically a poor outcome. Treatment, education, initially neglect glasses, which we all use in our setup, and RTMS. So very important, early recognition of visual spatial inattention helps to improve the functional outcome. So this is the patient whom I am talking about. Now he has been discharged a couple of years back, and this patient is now has been promoted to the rank of ACP. Just a few days back, he came to my OPD. He's doing very well. Mrs. BB, 45-year-old old female, subarachnoid hemorrhage from an echomanurism, VP shunt, E1 VT M3. So this is her that's her CT scan. If you can appreciate the aneurysm from which bled, and she was in coma for almost 4 months. So this is in Bengali, which I can translate for you all. So after 4 months in comatose stage, Mrs. Beraful Bibi, or sorry, the lady has been able to get back to her senses. Now this lady is actually walking around. She has a bit of cognitive behavioral issues mainly, but otherwise she's independent in her ambulation, independent with her daily activities. Music therapy, just a short note on this. As I mentioned, we practice music therapy in our setup as well. So what does it do actually? It stimulates the superior temporal gyri in healthy adults. That is what we use for these comatose patients. Now, if you appreciate here, this is from long back ancient history, which actually we are using now. So use of gamma enhancing binaural beats in cognitive rehabilitation is an important. You have to understand, these individually might not give you the best results, but these have to be clubbed, and you have to individualize the patient's need. Based on that, you have to use which and when, that you have to assess and find out. Again, the same thing, spinal cord injury, diagnosed, came to our hospital from Germany, and he was a C2 Asia A, started rehab as early as possible as we could. The patient is now back on his pins, walking around, back to his business. He's happy, family is happy. Again, the same thing with the stroke guy. He's now independent, back to his IT job. We started rehab because he was transferred from another facility within 5 days because he didn't need any surgery. So conservatively managed in another facility, sent to us, started rehab as early as possible in the acute phase, independent and back to his IT job. So there has been a shift in paradigm. Why? Because there has been increased life expectancy over the years. There's change in people's attitude and improved awareness about our quality of life. Now, patients and relatives actually on their own seek rehab, expert rehab advice and care. So rehab is now not a luxury. It has become a necessity. Are there any challenges? Lots of challenges. We need a fully equipped rehab setup, an expert multidisciplinary team, resources, both finance as well as personnel. We are lucky that our institute has provided us with all these. The only reason, because unless until you give, you won't be able to get anything back in return. We have been able to give them two things. One is a patient outcome through our acute early rehab services. And obviously, we have been able to give them a lot of revenue generation. Recent advances, again, VR, EMG, biofeedback, robotic, HBOT, and RTMS. I am not going into the details. We have VR set up, EMG, biofeedback, and robotic technology. We are getting the robotic technologies very soon. So HBOT, It may reduce, Cochrane says it may reduce the risk of death. There is limited evidence that survivors have a good outcome. Again, VR, it is helpful when used as an adjunct to usual care. EMG biofeedback plus standard physiotherapy. So conventional therapy that might improve the outcome. Robotics, in the next few months, we will be having our robotics, our indigenous made robotics as well. So again, it might improve. So why I am trying to emphasize on these words, it is just to reiterate that conventional rehab is the cornerstone of the proper outcome. These are just adjuncts, but we need to know when, how, where, and on whom to use. RTMS mainly helps in aphasia. Now, so take home message. I am a strong believer in early, preferably from day one, rehab is the key word to successful outcome. There are a lot of, you might or you will come across this statement, comment. There is no rehab potential in this patient. That's a myth. Every patient deserves a chance and every patient will benefit from rehabilitation. That is the fact. Still, conventional therapy is the cornerstone of rehabilitation. However, combination of skill and technology gives a better outcome. Isn't this what we want at the end of the day? A family reuniting after holistic rehabilitation. Look at this guy. This guy actually had broken both the bed rails initially when he was admitted under us. Now he's absolutely happy with his family. So the past cannot be changed. Change our life, change your life today with rehabilitation, within brackets, acute rehabilitation. Thank you.
Thank you, Dr. Suparna. We expect some questions from the participants of the webinar regarding any queries or any suggestions with respect to this talk. In the meantime, before getting in questions, I have some points to discuss, like how do you manage outreach services in your department? Do you have separate people for outreach rehab, or how do you manage that part?
Yeah, so we have a completely separate outreach team, and these people do not merge with our actual rehab team. Only as and when needed, if there's an emergency, they come and help us. But these people are actually handling the outreach services, and we actually deal within a radius of 5 to 6 kilometers. So the first criteria of joining our outreach team is you need to have a bike.
Okay, who are the members in your outreach rehabilitation team?
Now members in our outreach team they are mainly the physiotherapists, occupational therapists, speech language pathologists, and even the rehab psychologists as well. So the full team, but the chunk of this outreach team is the other physiotherapists.
Do you suggest this environmental modifications? Do you give emphasis on that environmental modification at home?
Absolutely.
For various neuro conditions?
Yes, so we actually do it through two ways. The occupational therapy team knows how to handle it. So first of all, when the patient is with us, we have a functional rehabilitation setup where we actually simulate home in the hospital, like a kitchenette, like your toilet. So we have a functional setup. Now, whatever problems the patient is facing while in the hospital, we try to work on that. Sometimes what happens, the patient might not be transferred under us. So these patients might go home and they come to our OPD. We again do the same thing in the OPD as well. Thirdly, the patients who are actually not being able to come to us, what we do, we ask the relatives to send us a video of their house so that we can modify their environment. because a lot of patients come to us with Parkinson's, elderly patients, and so we need to really modify the environment. Number two, along with the environmental modification, we need to provide these patients with assistive or adaptive devices as well, which we all do as well.
So we have started some questions, getting some questions now.
Sure.
After TBI, we are getting many patients with the agitated state and difficult to communicate with them. How to manage these cases and musical therapy, how frequently per day can be prescribed? First, there are two parts of the question. How to manage a agitated patient of TBI?
Sure.
Where it's difficult to communicate with them. I mean, the cognitive problem is there.
Yeah. So actually, agitated patients, they are mostly in the RLS stage 4. So that's that in one way, it's a good sign. Now, rather than being in the RLS 1 or 2. Now, how to manage? Two ways. One is pharmacological, one is non-pharmacological. Pharmacological, we all know how to manage. There are a few medicines which we can try. But again, we need to involve our psychiatric colleagues as well. We might start off with the medicines, but definitely it is always medico-legally important to get the psychiatrist involved as well. Non-pharmacological. Now, if you have the first thing which I am actually dead against is tying up patients. So physical restraint, both physical as well as chemical restraint worsens agitation. But sometimes you need to only when the patient is unsafe for himself or for the environment. Now, sometimes what happens, if there are patients who do not have tubes like a NG tube or tracheostomy tube or even a catheter, we actually talk to our psychiatric colleagues because they have a separate ward and they have a couple of rooms where they can handle, because they have this setup where they can handle extremely agitated patients. So if you really ask me how to handle these patients, one is start off like you need to provide them with a proper environment. Sometimes it is not possible in the hospital setup. Ideally, these patients should have a one-to-one communication or one-to-one services. Number two, he has to be in a quiet environment, which is not possible in a hospital setup. Number three, you need to actually we need to actually cater to these patients on the ground, which they usually have a crake bed, but that is also not possible in all the hospital setups. So ideally, practically, if we have to handle these patients, we need to start them on some sort of chemical restraint, means medicines. Get the psychiatrists involved. Get your own rehabilitation psychologists involved. And with time, we have seen that these patients really improve over time. So you need to be a bit patient with these patients as well, because they are all in their RLS 4, just coming out of the coma stage. They're agitated. Just maintain manage their agitation to that extent where the rehab doesn't get affected.
Okay. One more question. How do you deal with chronic stay of patients? How we set up our mindset as physiatrists in a positive way for such long time?
Very important question. How do you deal with chronic stay of chronic stay? There are a lot of problems. There will be problems, but again, you need to individualize each problem and solve them. Let me just put a few points one after another. Number one, the first thing is finance. So once the patient and the relatives understand that their patient is improving, and the initial counseling as a rehabilitation physician with the relatives is extremely important. What I usually do, and our team members like Dr. Gaurav Sannasi, I think he's here. Hello?
Please continue. Somebody has opened his mic and in background noise. Please continue.
Okay, fine. So what usually I do, the first counseling, the first interaction with the relatives is we try to put across a clear picture, as clear as possible, to the relatives, number one, which actually takes away a lot of burden from your shoulders. Now, once you do the initial counseling in a proper way, mentioning to them that, look, when your patient is with us, which you want, and also we want, this patient might develop an infection for which I cannot tell you that, cannot say for with conviction that this patient might not have an infection. So that thing you have to explain to them, because once a patient is in the hospital, the hospital length of stay improves and your risk of infection also improves. So this is something which you need to explain to that patient, that if the patient is there, risk of infection will be there, but we will try to handle that. But I cannot promise you that this patient will not contract an infection. Number one. Number two, we have to be very clear about the finances. And as much as possible, try to be away from that financial thing. We do not deal with the finances. I cannot help you out with the finances. This, whatever financial burden will come onto your shoulders, you need to talk to the admission team, discuss amongst your relatives, and then take a decision. One thing you have to learn as a physiatrist is to share the responsibility of the team with the patients, because that is very important, because we deal with chronic stay patients. Now, again, when the patient is admitted with us, we have a ward. That is what I told you. We need to get these patients off tracheostomy, off the tubes as early as possible, so that we can get them on our ward. On our ward, we have a lot of entertainments. Like we have a TV, we have carom, we have a few sports thing, which actually the patients get involved. Now, what happens? Throughout the day, the patients are involved in their rehab activities. 9 o'clock, the department starts, 11:30, 12, continues. Then you have your lunch, take a rest for an hour. Again, the drilling starts. So 9 to 5, these patients are fully involved in their rehab activities. Now, once the rehab activities show the outcome, automatically the patients will start getting motivated. It's of no use when a patient is just lying in his bed without doing anything. Then the patient gets demotivated. But we actually try to get all sort of activities to help them out with. We also involve the rehab psychologists with all our patients, so that we pick up their mood problems as early as possible and also deal with them earlier. So that is a very important part of our process and system.
We are lacking that part, but one thing is sure that being a profession of physiatrist, we should have patience on that. We should have spend adequate time for discussion with the patients with their problems. So one should have adequate patience to listen their problems and try to involve with the patient, which we are lacking. That's an important thing.
Very important, because unless and until now, look, I think the very important part of this whole rehab process is introducing yourself to that patient. Once you introduce, once you start working with that patient, you actually develop a bond. Let me tell you one thing. If you have a neuro rehab or a rehab ward to yourself, that is basically a family. And once that family bond starts growing, patients, when they get discharged, they actually cry when they go home. We have had so many patients who definitely, this is not their home, but they still keep communicating with us. When they go home, the nursing staffs have actually taken videos of those patients. Their tears rolling down their cheeks. So this is the beauty of having a rehab ward, and this is the beauty of the therapists, the team members interacting with them. One thing, it is not that always I can go and meet my relatives or my patients every day, but you have a team. You have a very well-knit team who will actually share your burden, who will actually share the responsibilities, and the outcome will be the same because your goal setting has already been done, and every week you are actually working on your goals with your rehab team, and you are resetting your goals as well.
Okay. Quickly summarize. Just summarize only few thing. One thing only. Just how doing median stimulation in your ward for in cognitive patient, and second part is transcranial cranial magnetic stimulation. These two. But can you just highlight 1 minute on this?
Sorry, Dr. Sahoo, just
Median nerve stimulation for coma arousal in
median nerve stimulation. Yeah. Look, median nerve stimulation, as we all know, it has to be on the right hand because that is how the pathway works. Now, to be very honest, we have used it on almost 14 to 15 patients. Out of that, like we are still collecting data. We have seen that not more than four or five patients we have really got much uh, uh, a good outcome. So actually, it is not that median nerve stimulation will work as a miracle in the next few days, because it's basically for 2 weeks, for 8 hours duration. So you need to have that machine, and that machine is basically has to be tailor made. It is very difficult to make that machine because we actually spoke to a company and they made that machine for us because the frequency is very different. So we have to use it for 8 hours. We have to choose our patients, and that is for 2 weeks. So in a single day, we can use it on only 3 patients, 2 or 3 patients. Now, median of stimulation outcome doesn't come just like that. What has been shown evidence wise is over a period of time, say in the next few months, if median of stimulation has been applied on a patient, his or her outcome could be better than if it wouldn't have been applied. So that is the crux of the whole story. It is not that we just put a median nerve and the next 10 days we find the improvement. No, it has to be used for a particular duration of time, and along with the conventional therapy, and we might find out the outcome which might not happen if we wouldn't have used the median nerve stimulation. So again, what I am trying to say that so what I am trying to say is that that we are still in the process of data collection, and probably in the next year or so we might come up with a robust data. That time we should be able to share it with you or the rest of the thing. And regarding RTMS, I haven't used it hands-on. We have an instrument in the hospital, but that is basically used for research purposes. But what I have seen when I worked abroad is RTMS helps in dysphagia and to a bit of depression issues. But yes, aphasia, there are evidences which shows that it could improve aphasia or dysphagia over a period of time. Good part about both these are there is no intervention in it.
Okay. Thank you very much. I think time is over already, 1 hour. It's no more question in
Yeah.
the chat box. So
Dr. Pabitra,
Yes,
I would
yes.
like to also add something. Myself, Dr. Sanjay Pandey.
yes, please.
Yeah.
Good evening.
Hello, hello, Sanjay.
Absolutely wonderful. Yeah, Suparna, good evening. Absolutely wonderful talk, Suparna. Mesmerizing, and the kind of passion and the intensity and the involvement which you have delivered the talk is really fantastic and wonderful, and
Thank you,
very
Sanjay.
motivating for all the juniors. But just to add, basically, our experience from here in Patna, that you talked about this goal setting is one of the very important aspects of in-patient rehabilitation. And also the timing of transfer of the patient from the other ward IPD to our IPD. Okay, many a times now we get confused when they send a patient refer to the PMR IPD for further rehabilitation. Now, many times there is no set guideline when to take the patient for IPD rehabilitation, and it depends on the type of setting you have at your institute, your hospital. Now, it becomes very vital. But no doubt, rehabilitation should start from day one. There is no doubt about it. And again, the timing of discharge. I am just coming to the last point. This decision has to be made very early. It's just like a goal setting. It also needs to be made very early. It's not like all of a sudden during the ward round, we deliver this thing to the patient and family that we are going to discharge your patient. It's very unrewarding. In fact, we have to plan accordingly. And in our ward, actually, what we have bedside notice board about each and every patient bed. And the goal has been set for each and every members of the team. Like, what is the goal for the PMR specialist resident, for the nursing officers, for the physiotherapist, for the occupational therapist, for prosthetic and orthotist, and estimated time of delivery or the goal achievement. This we have started since hardly last 3 or 4 months, but it is very rewarding. During ward round or discussion, you can interact with all the other team members, and they also feel themselves very much involved in this rehabilitation planning and management. Because you just told na, each and every one of the member has to play a role. And this family meeting, regular family meeting, what we have achieved, so that na, they will set themselves a target. Yes, this target we have achieved, now we are moving forward. So this is all actually, it's a quite long talk and very enriching talk, Suparna. Thank you so much. And Dr. Pavitra for arranging this talk to all of us. Thank you. Thanks a lot.
Thank you, Dr. Sanjay, for your good comments. I think that's a good decision you have taken, that you have made list of goals on the table bedside of the patients. So every faculty or every student or the physiatrist or nurse or the therapist, everyone must be aware about their role for that particular patient. And being a government setup, you are working and you have made that happen. That's a great thing, really. Okay. Thank you very much. And we are really privileged to have our Secretary IAPMR in the today's meeting. Thank you very much, Dr. Sanjay. And thank you very much, Dr. Suparna, accepting our invitation and had a good talk, good presentation about your clinical experience and neuro-rehabilitation. In future also, we'll expect some more talks on specific topics like on TBI, like stroke, this type of acute conditions as well as chronic conditions as well. So thank you very much. And at the end, I must thank the office bearers of IAPMR and the Secretary IAPMR, President IAPMR, and the PR team who is keenly involved in this recording the data and uploading in the YouTube. And thank you very much the IAPMR for providing us this platform for using this type of clinical events for the young physiatrists as well as the PG students. And I must thank my colleague, Department of PMR, SVNIRTAR, and our association, Odisha Association of PMR, for supporting me for conducting this webinar. Thank you, everybody. Thank you for joining with us. Thank you, Dr. Suparna.
Thank you, Dr. Sahoo, and my apologies again for taking a lot of time in the beginning because of my technical problems.
Not an
Quite
issue. That was a technical problem. It was not a part of you. Thank you. Thank you very much.
Thank you. Thank you very much. Take care. Stay safe. Stay well.